Welcome to this presentation. This will be a lecture on conversion disorders. We'll be covering the following: background and definition. We'll go through the list of conversion disorders. We will look at some clinical descriptions, epidemiology of conversion disorders, possible etiologies, what conversion disorder is not. So we will compare and contrast conversion disorder against malingering and factitious disorder. And we'll also compare conversion disorder with hypochondriasis. We will look at the management of conversion disorders, and we'll also go through some important aspects of psychogenic non-epileptic seizures. And finally, we will go through 5 self-assessment MCQs based on this lecture. Some information about myself. I'm a consultant psychiatrist based in Chennai, which is a city in southern India. I have worked for several years in the United Kingdom. Hysteria was a term first used by the ancient Greeks. As these symptoms were predominantly seen in women, it was thought that these symptoms were caused by a wandering uterus. The term hysteria is derived from the Greek word hystera for uterus. The term conversion disorder was used by Sigmund Freud and his mentor and colleague Joseph Breuer. In 1895, they co-authored a textbook called Studies on Hysteria. Their most famous case was a female patient called Anna O, whose real name was Bertha Pappenheim. Her symptoms included paralysis, visual impairments, and amnesia. Let us now look at the definition. Conversion disorder refers to the presence of sensory and or motor symptoms without an adequate underlying medical explanation. The word conversion is used as the assumption is that psychological distress is converted into physical symptoms. In ICD-10, the name given is dissociative disorder. The word dissociation is used as there is a seeming dissociation or disconnect between structure and function. That is, there is no anatomical structural abnormality that can account for the loss of physiological function that the patient is presenting with. Other terms that are used by clinicians include psychosomatic disorders, functional disorders, non-organic disorders, and so on. These are the general criteria for dissociative disorders or conversion disorders in ICD-10. There must be no evidence of a physical disorder that can explain the characteristic symptoms of the patient's presentation. There are convincing associations in time between the onset of symptoms and stressful events. So these two criteria should be met for any conversion disorder. In this slide, I have listed some examples of psychological stressors in children. And in this slide, I have listed the different conversion disorders. If you want, you can pause and go through these. And this is the list of conversion disorders in ICD-10. And we'll go through the clinical descriptions of dissociative fugue, trance and possession disorders, and multiple personality disorder. And at the end of the lecture, we will go through dissociative convulsions in detail. In dissociative fugue, the patient undertakes an unexpected yet seemingly organized journey away from home or from their ordinary places of work and social activities. The self-care of the patient is typically maintained, and there is amnesia, either partial or complete, for the journey. In trance disorder, there is temporary alteration of the state of consciousness. There is loss of personal identity. There is narrowing of awareness of surroundings. The patient displays repetitive movements and speech. In possession disorder, the individual behaves as if he or she has been taken over by a spirit, a deity, or a higher power. It is important that such behaviors which occur in culturally sanctioned religious rituals are not diagnosed as being pathological. Multiple personality disorder is also called dissociative identity disorder. This is a disorder that has been popularized by Hollywood movies. It is extremely rare in clinical practice. In this disorder, the individual displays two or more distinct personalities. At any one time, one personality takes full control, and each personality has its own memories and behavior patterns. We will now look at the epidemiology of conversion disorders. These disorders are more common in females, in both adults and children. They can occur at any age, but conversion disorders are rare under the age of 8 years, or for a first episode to occur after the age of 35 years. Motor symptoms such as paralysis or weakness are more common than sensory symptoms. About half present with multiple symptoms. These disorders seem to be more common in those with lower levels of education, particularly those who lack medical knowledge. They are more common in developing countries than in affluent nations. They are more common in lower socioeconomic classes. They are more frequent in rural areas than in urban areas. These disorders have an increased incidence in military men who have been exposed to combat. Conversion disorders are associated with comorbid depression or anxiety disorders. They are associated with antisocial personality disorder in males and histrionic and borderline personality disorders in females. Different etiologies have been suggested. So there is no single etiology that fully explains conversion disorders. The psychoanalytic etiology suggests that unconscious psychological distress is converted to obvious physical symptoms, and this is how the disorder derived its name as conversion disorder. Non-verbal communication of forbidden ideas or feelings in the form of physical symptoms. Psychological etiology suggests that these disorders represent learned abnormal illness behavior. For example, a child learns such behavior from another older member of the family who has conversion disorder. Cultural and social factors may also play an etiological role, whereby overt physical symptoms are more acceptable culturally and socially than unseen psychological pain, which can be easily dismissed. There are also biological factors which are likely to play a role. It has been suggested that impaired functioning of the corticostriatal thalamocortical circuits may lead to inhibition of voluntary movements. In conversion disorders with neurological symptoms, the limbic system, which is important for affect and emotion, may be overriding the motor or sensory cortices, thereby resulting in motor or sensory symptoms respectively. Conversely, in conversion disorders where memories of unpleasant emotions are being suppressed, such as dissociative amnesia or fugue, there may be normal activities of sensory and motor areas, but reduced activity of hippocampus, which is important for memory, and other limbic areas. Labile indifference is a characteristic feature of conversion disorders, and this may reflect reduced activities of both the area that is linked to the presenting symptom as well as the limbic system. What is labile indifference? So this is a French term. It literally means the beautiful indifference. It is seen in some cases of conversion disorders, but historically textbooks have mentioned this as a very important feature. This refers to the apparent lack of concern that is displayed by the patient. So for example, a patient with paralysis of a leg or arm, which in normal cases would evoke a lot of anxiety and distress in the patient, but a patient with conversion disorder might appear totally unconcerned. We will look at some disorders which superficially may appear like conversion disorder, but which are not. So it is important to recognize that conversion disorder is neither malingering nor is it a factitious disorder. So what is malingering? In malingering, the patient deliberately fakes symptoms and there is a clear external motivation, the so-called secondary gain. In factitious disorder, in this disorder also the patient deliberately fakes symptoms, but there is no clear external motivation. The assumption is that there is an internal psychological motivation, the so-called primary gain. Example of a factitious disorder would be Munchausen syndrome. So malingering can be defined as the intentional production of false or grossly exaggerated physical or psychological symptoms motivated by external incentives such as avoiding work, obtaining financial compensation, evading criminal prosecution, obtaining drugs, avoiding military duty, etc. Primary gain, as we saw earlier, refers to internal psychological benefit. So, due to physical symptoms, the underlying psychological distress is avoided. And secondary gain is characterized by external practical benefit. So, due to physical symptoms, the patient can avoid usual responsibilities. Conversion disorder is not hypochondriasis. So what are the features of hypochondriasis? A persistent belief of the presence of a serious physical disease. The patient is preoccupied with that belief to the extent that it interferes with their normal functioning. There is a tendency to repeatedly seek medical investigations, treatments, and second opinions. There is a refusal to accept medical reassurance, and it's usually chronic, at least 6 months. So in this slide, I have listed the differences between conversion disorder and hypochondriasis. So if you want, you can pause and note down the differences. So what are the general principles in the management of conversion disorders? It is important to try and avoid unnecessary investigations and specialist referrals, while at the same time having an open mind about the cause of the symptoms. Conversion disorders in general utilize considerable resources in terms of investigations and the time of medical specialists and other professionals. It is important to ensure adequate but not excessive investigations. If it's a neurological presentation, it is important to do a thorough neurological assessment, and if necessary, the patient can be referred to a psychiatrist. And if more than one specialist is following up the patient, it is important for all the disciplines to be consistent in the management that they are offering the patient. Can we be sure that a patient's presentation is functional, that is conversion disorder, and not organic? No. Similarly, can we be sure that it is a conversion disorder and not factitious disorder or malingering? Again, the answer is no. So what are the factors that suggest conversion disorder? The symptoms typically follow a psychological stressor. The presenting symptoms are atypical or unusual. The signs that are elicited by the physician are atypical. The results of the investigations are either normal or are not consistent with the severity of the symptoms. There might be a past history of conversion disorder. There might be a past history of depression or anxiety, or a family history of psychiatric disorder. But it's important to realize that past personal or family psychiatric history would be absent in most patients. Some of the following tests can be useful in distinguishing conversion disorders from organic disorders. So for motor paralysis or weakness, the Hoover's sign, the abductor test, and drift without pronation sign may be helpful. And for sensory loss, the midline split test may be useful. But this is not an exhaustive list, and depending on the presenting complaint, there are numerous tests that are available. I will just go through the Hoover's sign as an example. So Hoover's sign helps to differentiate organic from non-organic paralysis of the leg. So for example, the patient presents with paralysis of the right leg. First, ask the patient to push down with their right heel, so there won't be any effect. Next, ask the patient to lift your left leg against resistance. So due to synergistic contraction, involuntary extension of the right hip occurs, which is felt as a downward movement of the right foot. So this would happen in conversion disorders. Whereas if it is an organic paralysis, this downward movement of the right foot when the left leg is being lifted would not happen. So this is the Hoover's sign. So if you want, you can pause and spend some time going through this slide. Some classic conversion disorder presentations might be patient developing paralysis of their hand when having to sign an important document, for example, divorce papers, a child developing blindness after a major psychological stress or sudden loss of speech. Aesthesia abbasia refers to the inability to either stand or walk unsupported, with jerky bodily movements and waving of the arms. And when the patient is not supported and if they fall, they typically do not injure themselves. What are the general principles of psychiatric management of conversion disorders? It is important to approach any case with an open mind that it may be organic. So do the relevant clinical and other tests, but not excessively. It is important to realize that functional and organic illnesses can coexist. It is important to do a thorough assessment to identify any comorbid anxiety, depression, or personality disorder that may be playing a role in the presentation. It is important to remember that a patient with conversion disorder is not deliberately faking their symptoms. Explain to the patient gently that psychological or non-medical factors may be playing a role. Reassure the patient that we are not implying that he or she is lying. Explain to the patient that the symptoms that the patient is presenting with are not uncommon. And reassure the patient that these symptoms are likely to resolve on their own without any treatment, but if necessary, there are treatments that are available. What are the treatment options? So I'm just going to give a very broad overview. Reassurance, suggestion, and psychoeducation might be all that is needed for the majority of patients. Antidepressants, anxiolytics may have a role. Cognitive behavior therapy may be indicated in selected patients. The next three are mainly historical treatments, but some clinicians use these even now. So hypnosis, abreaction or drug interview, also called narcoanalysis or hypnoanalysis, which will involve interviewing the patient after administering a sedative drug, usually a barbiturate or a benzodiazepine. And psychoanalysis, this was the treatment that was traditionally used when conversion disorder was first recognized by Sigmund Freud and colleagues. Transcranial magnetic stimulation, which is a modern treatment, has been shown to be effective in some cases of conversion disorder. Because this is a relatively new treatment, I thought I'll mention some key aspects of this treatment. It is non-invasive. It uses magnetic fields to stimulate neurons in the brain. A large electromagnetic coil is placed against the scalp near the forehead, and this generates an electric current that stimulates the neurons. Repetitive transcranial magnetic stimulation is used therapeutically. And this is what it looks like. And there are both neurological and psychiatric indications for transcranial magnetic stimulation, and these indications are likely to increase in future. So I've listed some of these on this slide. And this treatment can also have side effects. I've listed the main ones on this slide. What is the potential mechanism of transcranial magnetic stimulation in conversion disorders? This treatment seems to have the ability to turn on selected regions of the brain, so it can reactivate the motor or sensory cortices which have been deactivated by unconsciously driven limbic activity. As a result, the sensory or motor function may be restored. What is the prognosis of conversion disorders? The most important prognostic factor is duration of illness. The longer the duration of illness before the patient seeks treatment, the poorer the prognosis. Most patients recover fully from an acute episode. Prognosis is poorer for those who do not fully recover or have repeated episodes. Potential good prognostic factors include sudden onset, clearly identified psychological stressor, higher levels of education, fewer accompanying somatic symptoms, no comorbid psychiatric disorders including personality disorders. A landmark study in 1965 reported that one-third of hysteria patients were found to have organic disorder during 10-year follow-up. However, more recent studies report a much lower figure. So this means that if after a thorough assessment a patient is diagnosed as having a conversion disorder, more often than not that would be the correct diagnosis even after a long period of follow-up. So we'll spend some time looking at psychogenic non-epileptic seizures. So the previous terminology included pseudo-seizures, psychogenic seizures, non-epileptic seizures. The ICD-10 term for this is dissociative convulsions. And just as with other conversion disorders, underlying psychological factors are considered to be the cause of the episodes. By definition, these seizures are unconsciously produced, but you may also need to consider malingering or factitious disorder in your differential diagnosis. It's more common in women. The usual onset is in early adulthood, but can also occur in children and rarely in the elderly too. It usually takes about 7 to 10 years from presentation to a diagnosis of PNES to be made, with the patient being prescribed different anti-epileptics in the meantime. So in this way it differs from other conversion disorders which come to the attention of doctors or the diagnosis is made much earlier. Up to 25% of treatment refractory epilepsy patients in neurology clinics may have PNES, and about 15% may also have comorbid true epilepsy. So that makes diagnosing the conversion disorder much harder. What are the factors that suggest a PNES? Occurrence only in front of an audience, that is when other people are present. No loss of consciousness. No tongue biting or major injury. No incontinence. Pelvic thrusting movements. Bicycling leg movements during the episodes. Side to side turning of the head. Emotional triggers such as arguments or panic attacks can trigger episodes of seizures. Longer duration compared to organic seizures. A stop-start pattern. Eyes open during the episode. Weeping or stuttering during the episode. Shallow breathing after the episode. No postictal accumulation of saliva, confusion or snoring, and labile indifference. Multiple vague somatic symptoms such as pain or fatigue. So it's important that true seizures might also be the cause of seeming pseudo seizures. So frontal seizures, complex partial seizures and absence seizures may be the actual diagnosis. Syncope, transient ischemic attacks and vestibular disorders may also need to be considered. Prolactin level was previously used to help differentiate true seizures from PNES. The assumption was that prolactin rises after a true seizure. However, further studies have shown that prolactin level also rises after pseudo seizures, and prolactin level may not rise after a true seizure. So it can be done as a supportive test, but it seems to have lost its diagnostic importance over the years. Normal EEG does not rule out a true seizure. However, repeated normal EEGs in the presence of repeated attacks suggest PNES. Ambulatory EEG is more useful, and the investigation of choice is EEG video monitoring. So in this, the episode is video recorded and the patient also has an EEG. EEG during the episode is normal or is not consistent with true seizures in PNES. And if attacks are infrequent, and if you want to do EEG video monitoring, these seizure attacks can be induced by intravenous injection of saline, hyperventilation, photic stimulus, or suggestion and hypnosis. The management of PNES, there is usually no restriction in activities such as driving. It is needed for pure PNES, whereas patients with the true seizures, they would have to stop driving. Supportive counseling, anxiety management and relaxation training, CBT, psychotropics, and address any other issues that arise that may be either in the past or actually happening in the present, psychosocial stressors that might be contributing to the PNES. They need to be identified and addressed. So this brings us to the end of this presentation, but before we conclude, we'll go through a set of 5 MCQs. This is the first MCQ. Which of the following is true regarding conversion disorders? If you want, you can pause now and select your choice. And the correct answer is B. Most patients recover fully from an acute episode. The other 3 options are not correct. Question 2. Studies on the epidemiology of conversion disorders show that. If you want, you can pause, go through the options and select your choice. And the correct answer is option B. Conversion disorders are more common in females in both children and adults. Question 3. Compared to true seizures, psychogenic non-epileptic seizures are characterized by. You can pause and select your choice. And the correct answer is C. The other 3 options are false. Question 4. When compared to conversion disorders, hypochondriasis is characterized by. You can pause now and select your choice. And the correct answer is A. Patients exhibiting more distress about their symptoms. And the final question. Which of the following is useful in a conversion disorder affecting sensory function? You can pause and select your option. And the correct answer is D. The other 3 tests are for conversion disorders affecting motor function. So we have now come to the end of this presentation. Hope you found the lecture useful. Thank you for watching.